Hi, welcome. So a really enjoyable session ahead, hopefully, running from 1:30 till 3. Myself and Deborah Harrington from Liverpool will be introducing sessions. We've got a 1:30 question and answer session as a round robin with a number of other colleagues. 2 o'clock, the president of our society, Simon Kendall, is coming to give us a talk on future of cardiothoracic surgery. And then a final session at 2:30 with a patient interview with Michelle McCaffrey. And then at the end, hopefully we've got some time for further questions if time allows. So if we kick off, I'm going to introduce you to Americos and Maria, both student representatives, one from Brazil and one from Manchester, to kick off the first question and answer session with myself, Deborah, Jill Hardman, and hopefully Melanie Jenkins.
Thank you, Ms. Evans. So I hope you can all hear me at the moment. So I'd like to invite all the panelists onto the stage at the moment. So if Ms. Hardman can also join us, and Ms. Jenkins when she's able to. So I don't want to take up too much time as we want to focus on the questions themselves. My name is Americos Aguirre, I'm from Manchester, and Maria is my colleague who's from Brazil, and we're both on the student SCTS committee this year. So before we begin, I'd like to introduce all our speakers today. So Ms. Evans is a cardiac surgeon from Leeds. She has a specialist interest in mitral valve transcatheter approaches. She has a PhD. She's a principal investigator in 2 clinical trials, and all the while is a mother of 3 as well. Ms. Harrington, who is a cardiac and aortic surgeon from Liverpool. She has an MD that she did in cerebral protection and thoracic surgery, and is a keen teacher, being an SCTS tutor, serving on the UK Aortic Masterclass sessions since 2013, and being a surgical faculty member as well for the SCTS. Then next we have Ms. Hardman, who is a ST7 trainee from the Northwest region. She is currently out of program doing her PhD in Newcastle, focusing on cardiothoracic transplantation. She's also very involved in teaching, being a NOTS a NOTS course tutor. She is a mentor with the SCTS and is also an interview panel member for the CST applications. And finally, we're hoping to be joined by Ms. Jenkins soon, who is a thoracic surgeon consultant from London. She has worked across Europe, but in countries like Paris and Copenhagen. She is, again, keen on teaching, being a surgical trainer and mentor for FY doctors, medical students, and trainees alike. And she's also a mother of 2, balancing this with 2 children and leading a social active life as well. So as Ms. Jenkins isn't here at the moment, we wanted to start with the questions, and I'll throw it to my colleague Maria, who can start the questions for the panel.
So hello everyone. The first question will be to Mrs. Betty Evans, and we gathered together some questions, and I will ask you some things based on your specialty. Okay. So Ms. Evans, what are your thoughts on cardiac surgery having to adapt to interventional cardiology and minimally invasive surgeries? And where do you see cardiac surgery moving towards in the future?
Okay, so quite a broad spectrum of questions there, but in essence, we have to embrace interventional cardiology and radiology. Before I became a consultant, I did a fellowship in TVAR and TAVI. And basically that gave me a little bit of knowledge such that I could feel confident enough to approach my interventional colleagues when I started working. There's a lot of crossover, and there's a lot of opportunity if you work collaboratively with those colleagues. There will always be a need for cardiac surgery, so don't let anybody tell you anything different to that. But in essence, if you can become, I don't like the term hybrid surgeon, I think that's horrible, but in essence, if you can acquire some skills, if you have negotiation powers, which all of us do have, we just need to find the right language, you'll find it quite enjoyable to work with these colleagues, and then you will share knowledge and they will gain knowledge from that, and it becomes much more of a cohesive approach to the patient, because it's the patient ultimately that you're treating, not your colleagues or the intervention. and the future, God knows.
Yes.
Hopefully the future's bright. So yes, I mean, I've got enthusiastic aspirations for the future of cardiac surgery. It's all about sticking real and understanding that innovation is important as well, because without innovation, cardiac surgery will slip behind. So that's why you have to stay abreast of the other specialties that are involved with the patients that we care for. Because I think in the UK, we've seen maybe a slip back in innovation in cardiac surgery in the recent times. And we do need to think about minimally invasive approaches and advancing those in our specialty.
Thank you.
I hope that answered some of your questions.
Yes. So I have another one for you. And it's about the problems and challenges that cardiac surgeons are faced with today. And what do you think it's the biggest ones, and how can you go around it?
The biggest challenges as a cardiac surgeon?
Yes.
Well, I think as a cardiac surgeon, you receive the patient at the end of the line often. So what we have to do, therefore, is educate much earlier in the sort of patient pathway. So if you don't engage in that stage and go out and embrace sort of really primary care level education, I mean, Debbie has done something with regards to aortic dissections, going out into the district general hospitals outside of the teaching hospital arena, educating from a patient awareness level that cardiac surgery can offer things, so you shouldn't be left at the end of the line. Otherwise, we'll be sort of the last man standing or the last woman standing in the patient pathway. So I think that's something that we need to consider. I mean, other things are like, it's a similar answer to the question I've said already, a collaborative approach with our colleagues. It shouldn't be a sort of competitive arena in the sense that it's one versus the other. It should be more of a joined up approach to what's best for the patient.
Thank you very much.
Thank you, Ms. Evans. Moving on to Ms. Harrington, you've chosen to focus your career partly on aortic surgery. At which point do cardiothoracic trainees or surgeons, at which point do they subspecialize in a field? Is it something that's done during your training? Is it something after its completion? And how did you come to focus on aortic surgery?
Okay, so thank you for the question. So I actually was fortunate enough to do a research project, an MD in thoracic aortic surgery at the beginning of my training. So that was before I became a registrar, and that was probably by default, really. It was being in the right place at the right time, and certainly at the time there was a lot of competition for registrar jobs in cardiothoracic surgery, and at the time it was necessary to have a higher degree before you could even get a registrar job, and obviously that's changed. The training pathway has changed quite a lot since then. So I already had quite a lot of specialist knowledge about aortic surgery before I even started my registrar training, and then as I trained, it became apparent that this was kind of what I was interested in and I wanted to follow, and I didn't want to just do cardiac surgery, and I think as time has moved on, it's become clear that I think it's good to have a niche, to have a specialty. I think there are fewer general cardiac surgeons now. Most people who end up as a consultant cardiac surgeon have some kind of specialty, whether that be aortic or mitral or minimally invasive or on pump or off pump. I think most people now have some kind of specialty. I think also with the shortened training time, it will be more and more important to have some kind of subspecialty fellowship. So I did a fellowship at the end of my training, which was in Liverpool, and then I became a consultant there. And I think that's quite common now as well. So I think a lot of people will end up doing an extra a fellowship before they become a consultant in their subspecialist area. So I think probably as you sort of get towards the end of your training, that's probably the time when you kind of realise what specialty or subspecialty area you want to follow. And it's those perhaps the last couple of years of your training when you kind of start formulating those plans and thinking about doing the fellowship in your chosen area. Hope that answers the question.
No, thank you. That was very comprehensive. Very comprehensive. Another question we had, I thought it'd be best to direct your way, is that you do a lot of teaching and mentoring through your different programs. So you must see a lot of trainees or medical students or doctors early on in their career. So in short, before we move on to Ms. Hardman, what would be your one piece of advice that you'd give to a budding cardiothoracic surgeon or a medical student?
I would say don't be put off. I think I wanted to do cardiac surgery from an early stage, actually, from when I was a medical student. And a lot of people would say, oh, why do you want to do that? That's, you know, it's hard work. It's, you know, you'll never make it. Or, it's, you know, it's going to be difficult. And it is difficult and it is hard. And I think certainly we do have to, we do work harder than a lot of other specialties, and there is no doubt about that. But if that's what you want to do, then you should do it, and don't be put off. So that's what I would say to people. Don't let people put you off.
Yeah,
is that okay?
Quite a positive response, I think, for a lot of us kind of doubting ourselves, especially early on our kind of journey.
Mm-hmm.
So I'd like to move on to Ms. Hardman before we kind of ask some more general questions. Hopefully Ms. Jenkins can join us. So Ms. Hardman, you're currently out of program doing a PhD. So a question we get from a lot of students is, what are the kind of academic research prospects in cardiothoracics, maybe compared to other specialties or in general? Is this a field where there's a lot of opportunities at the moment, you'd say?
So I think you need to be quite clear about what you mean by academic versus research versus clinical research versus that column you want to tick on your application form for jobs versus your general requirement to understand how we develop an evidence base, to be able to critique literature, to be able to inform your patients adequately about what the right course of action is. So all of those things can kind of be considered under the topic of research, but there's lots of different avenues for you to pursue within that. And I'll start by mentioning some of the other, perhaps lesser thought of. I did my master's degree in medical education and did original research as part of that. And I think medical education research is a really important developing area for academic practice in surgery, most definitely. So even if you consider yourself perhaps not to be that interested in basic science research, think about the other opportunities, including medical education and quality improvement. And in terms of pursuing higher degrees, as Debbie has already mentioned, lots of people in cardiac surgery have higher degrees, and that's a remnant of the way we used to recruit to the training pathway and the way training has developed. So there are a lot of people around with experience who can supervise, who are leading projects and who are carrying out research. But just remember that doing a PhD is a big undertaking. It doesn't have to be for everyone. It's not a necessary requirement anymore. And it also requires significant funding, a salary. You may have to move house, you may have to relocate. So all of these things need to be thought about when you're thinking about what kind of career you want to have in cardiac surgery and where academia might fit within it. More specifically, though, for that sort of box you want to tick on your applications and the more clinical research side of things that you can get involved in as an undergraduate, I think it's really important to recognise that all of us are continually ticking that box. Every year at the ARCP, we have to have our publications, our presentations as trainees. And so there are always people around departments who want you to get involved with those kind of things. There are so many opportunities for you to join in and help out, look at data, contribute to papers, abstracts, etc. And what I would say for all people who want to get involved in research, especially at undergraduate level or in your early postgraduate training, don't set your ambitions too high. And I'm not saying that to limit you, but recognize that you don't have to be producing Nobel Prize winning, lab-based research projects. Join with teams, collaborate, work with people who have experience, and build your skills in that way by learning from others. You don't have to go out there and find a project, come up with ideas, find the data, write the paper all by yourself. Work with other people, and that's how you get things done.
Great, thank you so much. That was quite a detailed response.
Maybe a bit broad, but I'm happy to go into more detail about those individual things. It's a big topic area, so.
It is indeed.
So I had some questions for Ms. Jenkins, but unfortunately she is not being able to connect with us. So I have questions for all of you, and if you can reply to us, that would be nice. And the first one is your thoughts on cardiothoracics continuing to be a one specialty or branching into two from the very start of training. What do you think about it?
This is open to either of you.
Yeah, anyone. Okay.
So, you want to go
Just
go on, Jill. First, Jill.
Seeing as none of us are jumping in, why don't I go first with my perspective on it? And I think we have to recognise, as Debbie's already spoken about, if you want to be a cardiac surgeon currently, you will subspecialise. If you want to subspecialise in an area, it becomes incredibly difficult to build your working week around that area, being good at it, doing it often, going to MDTs, attending clinics, finding patients, at the same time as pursuing all the other areas of practice within cardiothoracic surgery. And when I say difficult, I think it's almost impossible to do all of those things well. And as a big teacher and proponent of human factors and non-technical skills, I can tell you that no one does everything well all of the time, and it's even harder the more things you try to do. So it absolutely makes sense that we break down our practice into subspecialist areas and that we get good at those, because that's what our working week will look like. In terms of training, there is obviously a lot of cross-fertilization of those skills. And I think it is really important that we all have an understanding that comes from training in all areas and practicing in all areas, with the recognition that some areas of those practice have gone to other specialties as well. So it may be that there's opportunities for us to work more closely with other areas. I'm thinking about esophageal and upper GI surgeons and how that used to play out with thoracic surgeons. So I think that's where we're coming from. I'm happy for Betsy and Debbie to intervene on that question.
I think I was just going to add, and I think Simon will probably confirm this, but as far as I'm aware, there are not going to be any more cardiothoracic appointments in the UK. They're going to be either cardiac or thoracic. So there are still some consultants practicing in cardiothoracic surgery at the moment, but there won't be any more appointed, I believe, is the situation. I think that's right, isn't it, Simon?
Yeah, I agree. I think the knowledge and the skills needed, the commitment to the multidisciplinary meetings means there just isn't enough time in the week, and there isn't enough room in our heads for all the knowledge and expertise. So it's a natural progression over the years, which is a bit worrying, because if there are any major changes to treatment of lung cancer or atherosclerosis, you could end up having to change skills, but that is how things progress, and it's good for patients, and it's the right thing to do. And as Jill's just said, you can't be good at everything.
Yeah.
Thank you.
So I would like to let everyone know in the audience that we are looking at the questions you've been submitting. So please continue to submit questions. And I'd like to switch us over to a question that's been submitted. And we kind of touched upon this in the morning session, but someone was asking about the discrepancy between current consultancy posts and trainees in the UK at the moment. And they were asking about where you see this moving towards, and whether you think this is something that is temporary or whether it will change. So again,
Okay.
this is open to anyone.
Yeah. I think, Betsy, you haven't taken a vow of silence, have you? You're all right there.
No, I'm here.
That's all right. So if you don't, I'll just go first and see what everyone else says. It's temporary. We've been here before. About 13 years ago, we had the same anxieties and worries, and it sorts itself out. There is a glut of people who, like myself, were appointed in the 1990s and will be stepping aside for the younger, better talent than ourselves. In thoracic, there's growth with lung cancer screening and increased need for more thoracic surgeons. In cardiac surgery, we are working with the British Cardiovascular Society that there needs to be a surgeon of the day, surgeon of the week, and there'll be a need for more colleagues to fulfil that part of the service, and it will sort itself out. I think there's also some. I think there are people who are qualified looking for jobs, and they've got to find the right place for themselves. But I still think the people who are good colleagues, good operators, are still getting jobs, and therefore I'm still optimistic that it'll sort itself out. It's temporary, but as I said, that's just one view from myself. I don't know what Betsy and Debbie have to comment, and Jill.
I think I would agree with that. Oh, sorry, Betsy, do you want to go first?
No, it's okay. I was just going to say we have been here before. When we were, Debbie, starting out on our training, it was, why are you thinking of doing a specialty that's going to die? And that there will be no jobs at the end of your arduous training. I think workforce planning is notoriously not ideal, and things change, the situation changed. The other thing about cardiac surgery and thoracic surgery, it's quite an internationally recognized job. The skill set that you have, obviously there's language barriers and not everyone is a multilingualist, but you can transfer them to other places, and there's a lot of movement at a level of consultant and at a level of senior trainee. I think that ultimately, if you want to do the job that you want to do, you've got to realize that it's hard work, but it's because you want to do it, and it's there for the next 25 years. So it will work out. And I just think this doom and gloom that there won't be any jobs at the end of the line, we're recruiting people more and more because of a change in our work-life balance, the way that we structure our week. We're not all operating all the time. We are, as Simon says, adopting surgeon of the week or surgeon of the day plans and working as teams within a department. So that requires an increase in workforce numbers at a unit level. So I don't agree that there won't be jobs.
I agree with that, and I think also making yourself eligible as you can by doing something, having some kind of subspecialty interest is also probably a good idea. That will definitely help you get a job.
Okay, thank you. I'm sorry.
No, I was just going to say, to build on that from a trainee perspective, of course, it is always a worry, but we need to all be aware that just because you are appointed to a training post does not mean that you will automatically become a consultant at the end of it. And exactly as Debbie and Betsy have highlighted, you've got to decide what you want to be and what you want to do and grow yourself into that and take all the opportunities to do it, and recognize perhaps maybe a bit of flexibility in that as well, in understanding that you may have to move, that you may want to travel abroad, that you may want to do fellowships, that you might be desperate to be an aortic surgeon, but perhaps you could adapt a little bit and do some other things in the meantime, etc. So I think it's just about recognizing that flexibility and understanding that a lot of specialties go through this with workforce planning, and that these things do come around in cycles. So fingers crossed for all of us.
Thank you. I right now I have another question that as an international student, so I would like to know, what are your experiences with international applicants looking to specialize in cardiothoracics in the UK, and if you think there are any opportunities, if you're seeing someone, and if you know someone that has achieve this thing.
Okay, who's going first?
George, shall I start? We're a very international specialty. I think we have lots of colleagues from all around the world, actually, I think so. I think there are openings for international colleagues at sort of all levels, really. I don't know if you want to sort of give a more formal answer to that, Simon, at all.
I've got immense admiration for people who come from overseas. They leave their families, they leave their culture. They've got to get used to the National Health Service, which is not easy whatsoever. Most of us struggle with it. So, if you're coming from a different medical culture, it's even more difficult. And they bring a new perspective, and they bring amazing commitment. And quite often they're technically brilliant as well. So in general, they're an absolute asset to the specialty, an asset to patient care. And if they're not on the NTN pathway for career progression, then they can get trust appointed posts and fulfill their certificate of training through the CSER route. As a society, we are a national organisation to promote our specialty, and by doing that we support colleagues, and therefore we are as interested in our trust appointed doctors as we are in our NTNs. The SAC, it works for the joint surgical colleagues, and their focus is the national trainees. So myself as president and SCTS, we want to give equal opportunities for surgeons who want to train as cardiothoracic surgeons.
So just to reiterate that, in the group that I have 5 colleagues, I'm one of 6. I'm the only UK resident NTN. I have a Greek colleague who actually went through the NTN pathway but originated from Greece, had his degree in Greece, an Italian that came in through the specialist register from Italy, and 2 colleagues from India. So in essence, it is a very international specialty. It's not to say that it's easy to get into from an international perspective. As Simon has said, it demands an extra level of commitment, really.
Thank you. Thank you. I think that answered Maria's question quite well there. Yes. So we're in the last few minutes, in the last closing minutes. We obviously have several questions coming in, and we said we'd go back to these later on in the session. Just to finish off, question we keep getting asked from a lot of people is, what is the one thing that you find that is kind of the best thing about your specialty, and one thing that is kind of the worst thing that you've noticed about the specialty? So maybe a brief answer from all, or whoever wants to take this on.
Okay, the best thing is just the privilege of doing these amazing operations, and the challenge of every operation to get it right. My personal challenge is to do a procedure without an extra stitch. I still love that. I still love it. And I keep saying it, I still want to go back to the beginning and do it all over again. The worst thing is colleagues with a lack of insight and a lack of awareness. And, it just brings teams down, and it spoils the working environment, and it stops progress. And if I could have one wish, is that everyone has insight. And I don't have insight probably saying that.
The best thing is, as I agree with Simon, the best thing is it's amazing. It's an amazing specialty because it crosses anatomy, physiology, pathology, pharmacology. It really, truly is a wonderful surgical specialty. The worst thing, you wouldn't believe it, but there are very few females doing cardiac surgery. And the more we get, the more balanced, hopefully, that arena will become.
Hey, can I comment?
Sorry, Simon.
No, can I comment on that? You see, as a bloke, that gives me such insight. So out of all the things Betsy could have chosen, that's the impact it's had. And that's why it's got to change. Thank you.
It's all the conversations that we don't hear in the male changing room.
Maybe we want to really all those words.
the best thing is definitely the fantastic difference you can make to so many people's lives and their families as well.
And the worst thing?
Well, no, it's similar to what Betsy said, actually, I would say.
It's all good.
All the conversations we get left out of.
Yeah, so I would reiterate the best things. There is nothing quite like an open chest, and seeing things beating and moving is still amazing when it happens, and all of the other reasons that everyone else has given. The worst thing, I know we're all having a bit of a chuckle, and I'm glad we are, but in all seriousness, we have a lot of work to do in cardiothoracic surgery, and we need to be very honest about that. The culture is not a great place sometimes. And all of those disruptive type behaviours that we've talked about, the lack of gender equity, racial disparities, other prejudices, we have a lot of work to do to address those, but we're working on it, and the more people who get involved and want to change that culture, the better it will be for everyone. So we will all stick in there for the good reasons and work on the difficult ones.
Okay, I think, thank you everybody for those questions and answers. I think it's time to move on to the next bit of the session. Just to say, Melanie Jenkins does send her apologies for not being able to connect. And if anyone does have any questions that are specific to thoracic surgery, if you can put them on the chat and we will forward them to her. And she's happy to answer them or be contacted, so we can facilitate that. But I think now it's time for Simon to give his talk. So I'd like to welcome Simon Kendall, who's our current president, and he's going to talk to us about the future of the specialty. So thank you, Simon.
Thank you. Thanks, Debbie. Thanks, everyone. I've slightly altered the talk because I've listened to talks about trying to predict the future of the specialty, and it ends up being a personal opinion and a bit of a stab in the dark, and it's not easy to do that. And I've preferred to talk about the future of training, and to do that, looking at the past, looking where we are, and doing a little stab in the dark about the future. So let's go on to the next slide, please. Next slide. Thank you. So after our discussion that we've just had now, this is very apt. So 30 years ago when I joined medicine, it was really very middle class, the appointments to medical school. There was a lack of diversity, although there was a 50% female entry at that point. And the entry was nearly all 18-year-olds. There were a handful of people who got degrees from other sciences usually, and some medical schools had interviews, but some didn't even bother with interviews. They just took you on your A-level grades. And the medical school exams had year 1, year 2, and then year 5, and there was no in-course assessments. You could almost go missing for years 3 and 4, and then turn up at year 5 and practice do your finals. We were certainly brought up in a culture of doctor knows best. The patient was almost treated like an alien. They were from another breed, and that we were in a club of medicine, and we knew what was best. Towards the end of your medical student days, you were encouraged to get a locum house job. So the junior doctors were going off for their summer holidays, and it was quite nepotistic, because if you were friends with that houseman, you knew when they were going on holiday, and then you could get yourself in line for that house job, and that in turn would put you in prime position to get that house job from the consultant. So we were already learning a sort of nepotistic insider working relationship, how to engineer your own progression. So it was not done transparently, it was not done meritoriously. When you got your junior doctor's job, it was a 1 in 2 rota, or 1 in 3, so it was every other weekend on call and every other day on call, and there was a doctor's mess. So you had a group of people that you were working with, that you heard how they were working, they would help you, and very much a team atmosphere, which was very good. So next slide, please. So I found this photo on the web of junior doctors from the early 1980s, and you'll note the long sleeves. The The purple book in that doctor's hand is the British National Formula, which fitted nicely into your white coat pocket because that was all the drugs you had to know. And you can see that they're all white, and there was a lack of diversity in that group. Next slide, please. Now, to be a surgeon, it was absolutely clear to us that you couldn't be normal, that you would be almost certainly sacrificing your work-life balance. I mentioned in the morning session how surgeons didn't seem to have lunch. They seemed to start early. They seemed to be working late. And it was clear that it was exceptionally hard work. The first exam with the College of Surgeons, the primary FRCS, was the hardest exam I've ever taken. I've put a photo of the anatomy book that we literally had to learn cover to cover so that you could identify every bone of the foot, every bone of the hand, describe every cranial nerve and its course in great detail. So it was exceptionally hard work, and the exams were exceptionally hard, and it was clear that it was extremely competitive. And the discussions in the Q&A session reminded me that when I went into cardiothoracic surgery, there was no job progression. There were time expired senior registrars. So just as it is now, even then there was a feeling that it was not a good place to go. So if you did your 1 year as a houseman, junior doctor, which is now FY1, FY2, you then had to target a senior house officer job, teaching anatomy to medical students, and also usually combined with an accident and emergency job. And it was always quite sobering because I got an anatomy job in Sheffield Medical School, and you didn't feel like you were getting older, but when you were 24 years old, meeting all the 18-year-olds again, you suddenly realised that you'd gone through some training. Right, next slide, please. So you got your primary FRCS, and then you had to look for pre-fellowship surgical rotations. So it's a bit like now, look, this was the point now where it's like looking for the national training number. And these were 2 to 3 year rotations of 6-month attachments, which might or might not include cardiothoracic surgery. And you would get a really good array of surgical exposure, and something that I think is currently missing in the current training, and the danger of going in at ST1 is that you miss out on exposure to plastic surgery, urology, or on-call. The Part 2 FRCS exam, you'd choose to do it in Edinburgh or England or the Glasgow or the Irish College. The English College of Surgeons was renowned for being the hardest exam to get. At the time, there was a vague curriculum. There was a lack of quality assurance about the exams, and the success and failure really depended on the whim of an examiner. And I can speak from personal experience because I knew one of the examiners, and I was told after I failed the FRCS Part 2 that I'd passed every single section apart from one because the examiner took a dislike to me. But that was life at that time. Next slide, please. So with FRCS completed, so you were a Mr. and not a doctor anymore, you almost had to take a backward step and get a premier senior house officer job in a cardiothoracic unit. So whereas nowadays you've got a run-through training with national selection, at that time you had to take a step back. And again, it was about getting the connections as opposed to the competencies. You were establishing that you were a reasonable doctor, a reasonable surgeon, and get friends in the specialty. And at this point, some colleagues would even take 3 years out to do their research degree and do a Master of Surgery. You'd hope in that SHO job, that senior house officer job, to be able to learn to take veins, do thoracotomies, open and close chests, and also get that ITU exposure and do reopenings with the senior registrar. Next slide. So as Charlotte was talking in her presentation, as a registrar, you got your FRCS exam. You had to remain competitive. It was not run through training. You were now competing for the senior registrar post, and you had to write papers, and you had to hope that if you had good hands, you'd start to do the top ends and the coronary bypass operations. You might start doing lung resections. And at that time, we did esophageal surgery as well. And it was always remarkable to me how when I did general surgery, esophagectomy was a consultant operation, And then in cardiothoracic surgery, esophagectomy was put at the end of a list for a registrar to do. And what was even more remarkable was that the patients seemed to do better with that care than they did in general surgery. There were no clinical-based assessments, ward-based assessments. You kept a log of your cases, no question of quality or feedback or reflection. There was nothing else. It was a covert progress, no supervisor reports, and really you were dependent on the informal conversations of your bosses saying that whether you, and as Betsy and Debbie just said, we were mainly men, and I hate to use the expression in these modern times, but they were assessing if you were a good bloke and whether you were going to be able to progress and be a good surgeon. As a registrar, you started to run the department with the senior registrar, and the senior registrar job was really the big leap. Once you got your senior registrar job, you were likely to get your consultant's job. Next slide, please. It was highly competitive to get it, and you became the hub of your unit. You ran the registrars, you ran the theatres, you told the consultants what was going on. And that's when you were really operating 4 days a week as a senior registrar, and you got a huge amount of experience. If you were good, you could only spend 1 or 2 years in that role and you become a consultant. And if you were exposed and struggled, then you would be overlooked and you become a time expired senior registrar and not get a post. Next slide, please. So when I reflect back, there was a lack of diversity. There was a lack of opportunity for everyone. The exams were very hard and they were a lottery. It was an extremely tough on-call commitment. Fundamentally, it was a one-in-one most of the time, and work-life balance was affected. However, you had a great sense of responsibility. You really felt like you were a doctor. You really felt like you were a surgeon. The progression was covert. There was nothing written down, and it was uncertain. It certainly made us prepared to be an independent surgeon, but we weren't necessarily prepared to be a team player. You could end up very selfish in your outlook. And there was certainly, you could get your consultant's job with big gaps in your knowledge and professional experience. Next slide, please. There have been some major changes that have caused training to be transformed. I think the European Working Time Directive is the biggest change, limiting the number of hours worked per week, which immediately meant that you couldn't have the 1-in-2, 1-in-1 rotas, and you needed more middle grade surgeons in the units. Instead of having interviews at every hospital for registrar jobs and senior registrar jobs, we went to national selection. And also we went to run through training. So instead of having to compete, you get your first job and then you were guaranteed to be trained all the way through. There have been some factors on public health as well, that the ban on smoking in public places has had a profound impact on the incidence of heart disease and lung cancer. We've had other medical interventions such as stents, percutaneous coronary intervention. And as we've said, we've separated the mixed practice surgeon, whereas we used to do a couple of cardiac cases and then a thoracic case at the end of the list. That seemed reasonable at the time, but it's clearly that was 1990s practice and not the new millennium. And it's only right now that we've moved away from the mixed practice surgeon. It's cardiac or thoracic. And the other big impact we've had is that we now quality assure our outcomes, and there is performance monitoring for patients for their safety. Moving on, next slide. So when I reflect where we are now is that we have much more diversity on medical school entry. There is more opportunity. I do feel sorry for students and junior doctors now in that there seems to be continuous assessment for you all. Whereas we did our time at medical school and became doctors, and we felt that we'd achieved qualification and responsibility. I think we've taken that away by calling them foundation year 1 and 2. It sounds like classrooms at school rather than responsible professionals. And rather than joining a team of consultants and a ward, it appears, and I'm an educational supervisor for several foundation year, it's shift work and it's task orientated. The junior doctor is not necessarily the focus of the patient care. The hours are regulated, so the work-life balance is easier, but at the same time, you haven't got the joy of the doctor's mess and the bonding that we all had in our doctor's messes with it could be the obstetricians, the physicians, the A&E junior doctors. There was a real sense of camaraderie in the doctor's mess. And I think it's more isolated now, and there's less camaraderie in the junior doctor ranks. And as I've mentioned, there seems to be now continuous assessment with all the mandatory training requirements, etc. And at that time, you have to plan for the MRCS exam. Next slide, please. So I use this picture from, I think it's from Shrewsbury Hospital, but I just think for me it reflects the diversity now in doctors in general, and it's such a good thing to see. Next slide, please. Charlotte this morning went through the matrix for getting the national selection, and in a way this is good because it's transparent and it's absolutely clear what is necessary. It means that the nepotism that I described 30 years ago has now gone, and it's done on ability. It does remain very competitive, though. Next slide, please. We're phasing out the ST3 entry out of national selection, just focusing on ST1. Yesterday, Jonathan Afoki referred to the quality of the ST3 entry, which is without doubt, you bring in people who've done the plastic surgery, the urology, they've got other experience. But we are such a competitive specialty that we actually can select the best at ST1, and there really is no need for ST3 level now, I'm afraid. So for the moment, I think that will be phased out. And then when you get if you are lucky to be above the bar for ST3 entry, then you can choose your region for training by ranking. The number of years training has just been reduced by 1 year, so it's now 7 years. But whereas when I did it and nothing was written down about what you had to achieve, it is now absolutely clear what the curriculum is, and you have continued scrutiny and annual assessment to see if you're making those competencies. I do feel sorry for you, though, because it seems that every event is scrutinised, and whereas Farah and Karen and I could make mistakes, and which we are human and we all make mistakes, now it seems if there's a mistake is made, then you have to document it and reflect on it, and it's on record forever, which I'm not sure is necessarily constructive. In our own specialty, we are unique in the world as a professional membership organisation. We offer national trainees, and now also we're moving to our trust-appointed doctors to offer free education based on the curriculum. And it's a common expression is, what does the society do for me? Well, I think it's absolutely clear for trainees, we are offering you education based on the curriculum. And I think that builds our sense of community as a professional society. And there's a specialty quality assured exam at ST6, which tests you in the broad knowledge of cardiac, thoracic and congenital surgery. And as an examiner myself, I know how fair that exam is. It's very much based on equality and diversity. Next question, please. Next slide, rather. If you don't get into NTN training, then you can get trust-appointed posts at middle grade level, and you have to keep a log and achieve all the competencies that the national trainees are achieving. And you get your certificate of specialty training through the General Medical Council. It's the complete curriculum. It's absolutely equivalent to the national training number. But to be fair, there's almost less scrutiny than the national training numbers, which makes it probably a little bit more palatable. But at the same time, there's the lack of certainty of progression, which makes it much harder for international applicants. And just as with the national trainees, they will take the specialty exam as well. Next slide, please. So at the moment in 2021, most of the training rotations in cardiothoracic surgery require you to be a resident on call. and the hours are limited, so your work-life balance is possible. But I think what is a frustration is that almost half of those hours are spent holding the bleep, delivering the service to the ward. And it's important you get those skills early on in your training. But really, it is, as I mentioned, the old senior registrar used to be in theatre 4 days a week. The senior trainees do not need to be holding the bleep, writing up furosemide and checking urine outputs. We need to change that. And equally, sleeping in the hospital at night, dealing with things that allied health professionals can deal with is not good use of time. My observation now is that the junior surgeons, the junior colleagues that get their certificate are incredibly knowledgeable, extremely professional, they're excellent education. But I wish for them that they have more time in theatre and have more independent operating so that they are more confident and competent in theatre. Okay, next slide, please. Because of this lack of experience and confidence, a lot of people get their exam and their certificate, and they'll plan for a 1-year fellowship, often abroad, where they'll get good surgical experience. And there are several scholarships available through the society to help fund those scholarships. And then you start competing for your consultant post. And as I put at the bottom, workforce planning is almost an oxymoron because it is very difficult to plan. And yes, at the moment, this feels like there's a backlog, but within no time, we'll probably even be short of trainees to appoint to consultant posts. Next slide, please. So when you get your consultant post, you would hope that it's nirvana. You would hope that you've reached the end of your journey, your A-levels, your medical student days, your junior doctor days, your surgical training. You would hope that it's perfection. And may you be part of a functional team. All through our experience, it's always good to have a mentor, and particularly when you get a consultant post, it's really good if you've got a good mentor to bounce the issues that you're having, the plans you got for your surgery, the problems you might be having with your colleagues, but that's really good support. And it is a good idea that you start with a good run of cases that give you confidence. You don't want to start with a poor run that breaks that will. Next slide, please. So your consultant post will be in cardiac surgery or thoracic surgery or congenital surgery. And of course, there is thoracic transplantation as well, which can be most rewarding. We've just commented that every case is a challenge and a privilege. I cannot believe the bravery of all our patients to put themselves in our care and jump into that black hole of general anaesthesia and come out the other side with their chest having been opened and closed. They are all remarkable what they go through and the trust they put in us. Completely enthralling specialty, never a dull moment. And this is my little toe that we are seeing continued development. Cardiac surgery has desperately now needs to move to more minimal access surgery and robotic surgery. Thoracic surgery is showing us the way. There was a point where thoracic surgery almost looked like it was a dying specialty in the 1990s, and it's an absolute pleasure to see it thriving now, and them showing us the way that we should innovate and give patients better care. Next slide, please. So for the future, I think COVID has really been a benefit to showing us the reality of virtual education. It can be done, it is effective. We're not using simulation enough. We should be coming to the theatre able to hold a needle holder and do stitching without having to think about it. But too often that's not the case. We've not fully got it right in national selection, identifying the right attributes for a surgeon. There are some people who are incredibly high achieving, achieve national selection, but actually they just haven't got the qualities to do cardiothoracic surgery. And for their professional happiness and for the specialty, it would be much better if they moved to somewhere where they're going to be professionally content and not continually challenged. As president, my wish, as I've said about Insight, is that we continue the journey from the independent surgeon to functioning teams with mutual support. We still haven't got that completely right, and we'll continue that journey. Next slide, please. We are now in the process of putting some of that stuff right. We want that there's more access to theatre for surgeons in training. And to get them non-resident in their senior years, ST6, 7 and 8, that they should be non-resident. And I do challenge medicine as a whole, and surgery is that I opine, and a lot of people seem to agree, that foundation year and trainee is a derogatory term. And we need a term. We don't get on an airplane and hear that the first officer is a trainee pilot. It's the captain and the first officer, and I think we should give our junior colleagues more respect, more responsibility, more professional accolade by giving them a proper title. We should think about more reasonably priced exams. We're giving free courses in SCTS, and as I've mentioned, we should ask, get colleagues in the right place at the right time. And if they're not progressing, it's much better that they move early than stay too long. So, Debbie, I will stop there. I hope that's given a view of the journey and a little glimpse of where we're heading at the moment, and happy to take questions.
I'll go first, Simon, before everyone joins the stage.
Thank you very much, Simon. Thank you for that talk. I think there are a couple of questions on the Slido. Can you see? Are you able to see them, Karen?
I think it was mostly things that he'd answered before about entry into core training versus ST3, ST1. But I think it was really interesting your view on respect for junior doctors, and I think that is a really interesting perspective and something that I had noted had gone through training. What, apart from titles, what other things do you think we can do to really challenge that?
I see conversations about, and I can't get the damn word out of my head, trainee, but it's a derogatory term, and these men and women they are so intelligent, so motivated, so hardworking, done medical school, got postgraduate exams, and it's just not right to call them trainees. And my personal pride at being a senior house officer, a registrar, a senior registrar, and I've just talked about, the senior registrar was the kingpin in the unit and had a huge amount of respect. And we've changed that. And now the ST7 is on the same rota as the ST3, and the patients can't even tell the difference. It doesn't get you ready for consultancy. It will not be something I do in my presidency, but I'm just wondering if we can get the momentum. In the Federation of Surgical Specialties, there is real appetite that this needs to change. We talk about diversity and treating colleagues equally and women equally, etc. I don't think we're treating trainees properly. I think we abuse them.
Yeah, I think those are really, really interesting comments. Do you think that knots and human factors and some of the parallel courses that we run for non-technical skills are important in that? Because, we quite often recognise, my brother's an airline pilot, he's quite often horrified at the hierarchy in medicine and how we have such utmost respect for the person in the room because of the title, rather than someone being able to speak up and voice an opinion. And that's the difference between the captain and the first officers, and that respect in the cockpit. You're not even allowed to refer to your first officer as first officer. You refer to them on a first name basis.
Yes, yeah, I agree. I think across the table, my current junior colleague is Laura, and she's Laura. It's not, it's first name terms, absolutely. But I think from a patient perspective, and for the nurses or the physios or whoever, I think it is important to have some acknowledgement of ability and seniority. But maybe I'm wrong. Maybe I'm wrong with that. Maybe it should be a flat structure.
No, I think that's really it was an excellent talk. Thank you so much for that. I think we're going to move on to Michelle McCaffrey. And Michelle, your talk is actually pre-recorded, but if you stay on with us at the end, we'll be able to feed you some questions. So just by way of introduction, I'm Karen Booth. I'm one of the transplant surgeons at the Freeman Hospital in Newcastle, and Michelle comes from my homeland of Northern Ireland and came to us for services. Was it maybe 18 months, 2 years, Michelle?
September 2018.
Yeah,
so yeah.
You'll remember it way better than me. And just went through a real personal journey. I think all of the invited speakers this morning have spoke about how the patient is at the heart of everything that we do, and it would be really remiss of us not to at least share with you a really interesting patient journey. My version of Michelle's story is completely different to Michelle's version, which is why I've asked her to come along today. But from Michelle's perspective, medically speaking, she had an acute heart failure problem. She was put into an ambulance and transferred from tertiary care into a bigger centre in Belfast, and then thrown across to the Freeman. And it's a real success story for us in terms of heart failure, mechanical support device, and then decommissioning. But Michelle will tell you the real nitty-gritty of just how difficult it was to be a patient on that journey and her experience. So I think we'll hand over onto your video, Michelle, and then we'll have a chat with you afterwards, if that's okay.
Yep, thank you. On the 15th of September 2018, a crazy journey began for me that would lead me to my local hospital in Enniskillen, the Royal Victoria Hospital in Belfast, and on to the Freeman Hospital in Newcastle, and is the reason why I'm speaking to you today. It began like every other day did. I was mid-moving house and I had a 2-year-old son to run around after. And so as the day went on and the feelings of fatigue and flu-like symptoms crept in, I had no reason to think it was anything other than just that. I have always been a very active and healthy person, so it took a lot for me to hold my hands up and take to bed, which I eventually had to give into and do. Fast forward 24 hours and my first attempt to get up and pull myself together. My partner works in London during the week, and I was feeling guilty about not spending time with him that weekend. So I decided to go downstairs and just watch some TV on the sofa. I was sweating profusely and realised quickly that wasn't the best idea. On trying to get up, I suddenly collapsed, coming round with really bad pins and needles in my hands and my feet. My partner called 999, fearing something more serious was wrong with me. I was checked over thoroughly by the paramedics, and I was told I probably had a viral infection, and to check in with my GP the next morning if I wasn't feeling any sense of improvement. The next day brought much the same: extreme tiredness and severe flu-like symptoms, and me generally just feeling really sorry for myself. I rang the GP surgery that morning, and when I explained I didn't think I could physically make it to the surgery, they penciled me in for a house call later on that afternoon. Early afternoon, I rang my sister, who is a nurse, and asked her just to come and sit with me for a while. I was feeling really uneasy and I didn't want to be alone while I waited for the GP. I don't remember fearing that I was really ill, but looking back, I must have had some idea. In my attempts to use the bathroom, I collapsed again, but this time I was in no rush to come round. They say you know when you're dying, and I remember coming round, lying against the bathroom door and feeling something just ebbing away from me. Paramedics were called again, and again all my vital signs were fine, with the exception of the blood pressure, which was edging on the low side. This has been a recurring issue for me, so it wasn't a major red flag. By pure luck, my GP arrived at this stage with my medical records, which consisted of half an A4 page. She used some gentle persuasion and convinced me to go in for a few tests, with the likelihood that I would be back home again that evening. I've often thought what would have happened during these current COVID times, with the probability that I wouldn't have went in and I could have died in bed that night. That evening, I was admitted to the Southwest Acute Hospital here in Enniskillen, more I think to put some minds at ease than because anyone had any idea as to what was about to transpire. Bloods were taken and a chest x-ray was carried out, and early results showed a mild case of myocarditis, which could be routinely treated and would require just a 2 to 3 night admission. My family were sent home with reassurances I would be fit and well in just a few days' time. As the night went on and my results continued to come back, my situation took a massive turn for the worst. To this day, I've absolutely no idea what it means exactly in medical terms, but my troponin levels came back at over 6,000, which I'm told is pretty impressive. I was transferred up to coronary care, and whilst the care I received was absolutely first class, there was no hiding the fact that the staff were very aware I was a lot sicker than first thought. There really was just a sense of trying to get me through the night. I remember overhearing quite a panicked phone call asking for some assistance on protocol, and I demanded to know if they were referring to me. The next day, my father was awake before 7 a.m. and decided to ring and check how I had been throughout the night. He was surprised when the nurse in charge told him that maybe he should consider coming on in to see me. When he questioned this further, he was told that their advice now would be to gather the family together and make their way to the hospital. Shortly after they arrived, we were introduced to cardiologist, Dr. Susan Connolly, who explained what an echocardiogram involved, and she was upfront and honest that I was likely going to be transferred to the Royal Victoria Hospital in Belfast. This, for me, in my naive state, was worst case scenario. The echo seemed to last all of 10 seconds when she told me an ambulance was on its way and I was to be blue lighted to Belfast with a view of going on to the Freeman in Newcastle. It was obvious at this stage she had major concerns. My family and my partner were all understandably very shaken, but still didn't take in the seriousness of the situation. When I arrived in Belfast, I knew myself I was struggling. I was short of breath and really distressed. There was a hive of activity around me and a real heightened sense of urgency. I was more or less told straight away that I was indeed to be transferred to Newcastle by air ambulance, and the panic set in as to who was to travel with me. No one wanted me to travel alone, but it was a massive ask of anyone knowing how sick I was. My partner drew the short straw as he happened to have his passport in the car, and he was taken to one side and warned that when we were mid-air, he had to be prepared that if the worst happened, we were not in a medical environment. I was prepared for theatre, and they carried out a right heart catheterisation. I was later told that the information that the doctors gathered here in Belfast was instrumental in decisions made down the line, and the doctors in Freeman had nothing but praise for what those guys done for me. So on the evening of the 18th of September, I was brought in an ambulance to an airfield at Aldergrove Airport and flown to Newcastle. My spirits were high because I was able to joke with the firemen helping me on board and asked about the trolley service on this tiny plane. This was short-lived when a storm blew in and we had a really nasty landing. For the world's worst flyer, this may well have finished me off before any heart failure could. On the other side, I heard my accompanying doctor tell the ambulance driver to put his foot down, describing me as a lot sicker than I looked. I genuinely thought he was just trying to get home before the storm got any worse. From this point on, my memory does fade a lot. I remember my family arriving, the distress on their faces, and my overwhelming need to just sleep. They were told to go and get some rest, that I was going to be stabilised, and my course of treatment decided the next morning. Unfortunately, though, during the night, they got a call that I was deteriorating drastically and the medical team needed to take action to keep me alive. This is when we were first introduced to ECMO, which came to a shock to all of us. Whilst we knew it was keeping me alive, the inability to move due to the large cannula in my leg and the sheer sight and volume of my own blood in this machine in front of me was terrifying. I had 2 nurses with me 24 hours a day, one looking after my personal care and the other constantly scanning the ECMO machine for clots. When the clots did appear, it was a terrifying process, watching a team of doctors arrive in their gowns and the lightheadedness when the machine was turned off for those few seconds to remove the clot and the alarm sounded. Being awake and alert whilst on ECMO, I'm told, is very unusual. And I have to admit, both physically and mentally, I found it really difficult. During that time, I was aware of two realities. The first one is that it was time limited. And if I remember correctly, 8 days was the maximum length of time I was to be on it. The second is that I was now on a super urgent list for a new heart, and we needed that heart within 8 days. The days ticked by and nothing seemed to be forthcoming. Every time a door opened, there was a sense of expectation, and my mother cried with me, feeling annoyed with herself that she felt a glimmer of hope on hearing of a fatal car accident in the Newcastle area. That is the life of a person on a transplant list, only feeling real joy and relief when another family faced their darkest hour. And I thank God every day that was so short-lived for us. It was at this point that I first met Andy, one of the amazing bad nurses in the Freeman Hospital. He came into my room carrying quite a large metal pump and explained the workings of the VAD. This was my plan B as the end of the 8 days approached. As it happens, we were due some good news, and it came just in time. More praise was heaped on the team in the Royal Victoria Hospital in Belfast when it emerged that whatever tests they had undertaken during my short time with them, they were able to establish that my heart actually had the potential to heal itself, and I needed to keep my own heart. I still remember Karen standing in my room in ICU in her lovely familiar Northern Ireland accent and delivering this news. And so it was all systems go for the LVAD, and like so many other parts of this story, I had no idea what was in store for me. So on the 27th of September, I was taken to theatre for an operation to implant my LVAD. For those of you who are not familiar with this device, it is a mechanical pump attached to the heart and then hardwired down through the abdomen and attached to an external battery pack 24/7. My surgery was due to last 5 to 6 hours, but unfortunately I took a bleed. And although the operation was a complete success, it took a lot longer than predicted, which, as you can imagine, was really worrying for my loved ones waiting outside. My family were warned it could take 3 or 4 days for me to waken, but the morning after, my mum and my sister felt a compulsion to just come and sit with me in ICU. I must have decided that I had had enough rest, and I remember the tube being pulled slowly from my mouth as I came to. In hindsight, this may not have been a good thing, as those first few days post-ops were really distressing. I was irritable, nauseous, and generally just cross with the world. I felt like a stake had quite literally been driven through my chest, and I had a thirst so bad but couldn't communicate. I remember the feeling of my mum rubbing my arm and just trying to shake her off. The next week and a half is a blur of machines beeping, broken sleep, physio, and needles. The VAD largely went unnoticed to me as it was being mains powered, so I didn't have to worry about batteries or control panels, and the nurses were recording the stats. They tried to help me become more mobile, but the chest pain was immense, and I was shocked at how quickly I had lost movement. It was taking 4 nurses to turn me every few hours to avoid bed sores. My walls were covered of photos of my little boy, Tom, and I felt guilty when people sympathised over how much I must be missing him, when the reality was I just didn't have the headspace for that, and I had tried to just block all thoughts of him out. On the 5th of October, it was decided that I was well enough to be moved to the rehabilitation ward in the Institute of Transplantation. My family were so excited by this massive progressive step, but I was petrified and felt I wasn't ready after 2 weeks of 24-hour round-the-clock nursing. I was still catheterised and had still very limited movement in my legs due to muscle wastage from being bedbound for that time. I was wrong, and the care and camaraderie I experienced on that ward was world class. I was in Bay 2 with 3 other women of similar age, and we were told it was the first time they'd ever had an all-female bay. The nurses loved popping in during the day, knowing they were guaranteed a laugh. We took part in the weekly table quizzes as the Bay 2 Babes, and that became the name of our WhatsApp group. Our families got to know their families, and for 5 weeks, we were one big family. The VAD team organised for me to see a psychologist to deal with the impact of the suddenness of my illness had on me, and advise my family on how to deal with me as potentially quite a different person post-VAD. They were trying to be so upbeat and positive and got distressed seeing me have bad days. But they were told I had to be allowed to have these days, and rather than tell me how lucky I was, to let me rant and rave if I needed to. Some days, lucky was the last thing I felt. I had physio every day, and one day the poor physio didn't know what to say when I spotted it was raining outside and insisted that I go out and sit in the rain, because it was little things like that that I had missed. I was soon back on my feet, and once I had passed all the knowledge tests on managing my VAD, I was ready to go home with my chest wound, Endus tablets, 6 batteries, in-car charger, and quite a story to tell. The first few weeks at home went by in a bit of a blur. Coming from a small town, I was a bit like a local celebrity and was inundated with cards and flowers from well-wishers. In comparison to other stories I have read, I managed the VAD really well, and rather than letting the enormity of wearing it and people looking at me oddly get me down, I accepted it was the thing that was keeping me alive. The VAD team in Newcastle were in touch every few days, and I met with Dr. Dixon, who was to be my point of contact for cardiology in Belfast. She introduced me to a heart failure nurse, so I had the reassurance that help and advice was available to me locally. I had monthly VAD clinics in Newcastle, and it was great to connect with other LVADers and compare experiences. We would spot the telltale black bag on the flight and give each other a nod of recognition. In the middle of December, just 3 months post-surgery, I started to experience some pain and a burning sensation under the skin in my stomach and around the wire leading to my abdomen. Freeman were quick to act, and after sending through photos, they diagnosed cellulitis and tried me on a course of antibiotics. This unfortunately didn't solve the problem, and I was in absolute agony leading up to Christmas. The only relief I could get was lying flat on my back with ice packs. It was decided that I should fly over after New Year so that the team in Freeman could take a look. It was a long trip involving a very early start, a 90-minute car journey, and a flight, all while I was doubled in pain. On assessment, they told me that they could have went ahead and performed some minor surgery to remove the infected section of wire. But amazingly, they were so impressed by the progress my heart was making towards recovery, they wanted to try and suppress the infection and bring me over at the end of January for a full decommissioning assessment. Just as I was getting used to life with the VAD, it was very likely I was going to have to get used to life without it again. So at the end of January 2019, I spent another 3 weeks under the amazing care of the team in Newcastle. Not a stone was left unturned when it came to making the decision regarding the decommissioning of the VAD. I was apprehensive as I assumed that they would need to open up my chest again to reverse the process. I often compared it to many years ago when I climbed Ben Nevis for charity. I made it up the first time because I had a sense of naivety and no idea what was ahead of me. But to ask me to undertake it again, knowing exactly how tough it would be, and mentally, I don't think I would be able to go there. My fears were quashed by the VAD team, who explained that the decommissioning procedure was actually carried out while I was awake under local anaesthetic. The theatre was busy with people, but it was almost like a party-like atmosphere, and we felt that something really momentous was happening. I'm not sure of the exact statistics involving patients who actually get well enough for decommissioning, but I imagine it's in the small single figures. Even going back to the ward after the procedure, I nearly felt a sense of embarrassment or survivor's guilt, to put it better, seeing the other patients who I knew would give anything to be in my position. Whatever the waistline equivalent is of a selfie, I must have sent hundreds that week. The sheer relief of not having to carry the equivalent of the weight of a small baby around with me, and all the wires and batteries now gone for good. I think, though, that one of the hardest parts of my journey started when I got home. Obviously, I was overjoyed to be back with my family, but the security of a machine doing all the work to keep me safe was gone. Any tiredness or ache or pain, and I was panic-stricken, thinking it was happening all over again. My partner had went back to London during the week, and I had images in my head of my son unable to wake me in the morning, which resulted in a number of late night calls to family and friends. I seen danger in places I hadn't before. I avoided driving, crowded places, and even children's playgrounds, imagining all sorts of crazy things happening. I even ended up being admitted to hospital one night, convinced that my chest was tightening, when in reality, I had a cough and a sore throat. I mentioned a lot of this to Dr. Conley in Enniskillen, and she knew straight away that I was suffering from PTSD. She signed me up for the cardio rehab program she had pioneered called Our Hearts, Our Minds, which deals with both the psychological issues faced by heart failure patients, as well as the physical exercise recommended to stay fit and healthy. I was referred to a psychologist who explained to me that in a world where I had always felt safe, that wasn't the case anymore. And she gave me some great coping techniques, which I use to this day. The exercise class was interesting, to say the least, as in the average age of the participant was approximately 70 years of age, and I was the only female in the session. I think they all thought I'd walked into the wrong room at first, but we all listened to each other's stories, and I soon became a fully fledged member of the Zip Club, as we called ourselves, due to our matching surgical scars. Before the pandemic, I continued to travel to Newcastle on a regular basis and was delighted with the almost disbelief from the team as to how well I was doing. This gave me great comfort, knowing that I was being kept an eye on and knowing the symptoms I need to be on the lookout for. I've obviously had to reassess some aspects of my lifestyle, but life in general is back to normal. So that's the last 2.5 years condensed into 20 minutes. It's been quite a roller coaster, but thanks to the team in SWA's Coronary Care Unit, to the quick thinking doctors in the Royal Victoria Hospital in Belfast, and the entire medical team in the Freeman Hospital, I'm here to tell the tale. Thank you so much for your time.
Thank you, Michelle. That's absolutely amazing talk. I think that was absolutely inspirational. I'm sure everyone will agree.
It only took about 30 takes.
That was really amazing. So we do have a couple of questions for you from the panel and from the audience, and I would also encourage people who are listening to put more questions on the chat if you would like to ask Michelle anything. Michelle, couple of things. So what advice would you give to aspiring doctors or medical students about communication skills and about the way they interact with patients? Have you got any tips for them?
I would definitely say consider the psychological effects as much as the physical effects. I know that's not part of their remit, but I mean, I remember being in ICU and I nearly had an altercation with one of the consultants because he was like, you need to get up, you need to be exercising, you need to be moving. And I was just like, I can't, I physically can't, So I definitely would say that, like, consider the psychological effects as much as the physical.
Fantastic, great. And go on, Betsy. Betsy's got a question.
Hi, Betsy.
Betsy, you're muted. We can't hear you, Betsy.
Hello.
Oh, yes, we can hear you now.
Right, I've gone, but you can hear me, yeah? Sorry,
Yes.
I was saying I was blown away. I'm really quite emotional about your talk, which is
thank you, me too.
Now, I just want to know, have you ever given that talk before?
I gave it, sorry.
and the other thing that I wanted to know is, are you working? Do you have a job?
I do, yes, yeah, I do. I've worked in hospitality for years. I was a hotel, before I got sick, I was a hotel receptionist. And now I'm working in a beautiful country estate just beside where I live. I look after all the accommodation there. So yeah, I've worked in hospitality for 20 years more, yeah.
Oh, well done. Honestly, that was such an experience to hear it from your side. It really was amazing.
Thank you. It was quite the journey. So it was. You asked me something else and I can't remember now.
The other question was, have you ever given that talk before?
I have. Karen will tell you. I gave that talk. So let me see. I was decommissioned. I got sick September 2018. I was decommissioned February 2019, and I gave the talk locally here in the June. But I think that's whenever I realised there was something just going on up here, because I was super emotional.
So I asked Michelle, to come back to her original referring hospital, Betsy, because I thought it was really important for the staff to see that the journey can work, and that if you get the diagnosis quickly, you can get the treatment quickly, and that you can make it to a transplant centre quickly, and that it's not necessarily, even if there's not a heart available, there's other options. So Michelle falls into a really small proportion of heart failure patients that can actually have an LVAD that can be decommissioned. And when she talks about the right heart catheter, I thought that the community deserved, the medical community deserved the applaud of getting it all the ducks lined up. And we'll know, Debbie, as aortic surgeons, that getting all your ducks lined up and getting your diagnosis definitely makes a massive impact on patients, doesn't it?
May I ask a question, please, Michelle? That was an amazing talk, and you're going to be harassed by lots of us.
Thank God it's pre-recorded. I'll hand over the copyright.
You mentioned a slightly sort of cheeky question. You mentioned that you were sent home with lots of batteries and this and that, and a car. Was it a car charging of that?
The VAD actually comes with an in-car charger. I never used it. No, I was always really good. If I was ever going anywhere, I had like a full array of fully charged batteries, so I never had to actually plug myself in. But no, it's and funny for me, honestly, the hardest part of having the LVAD was the sheer weight of it. It is like carrying around a small child the entire time. Most people, because they're more discreet, carry them in the little shoulder bags. But I find just for weight distribution, I would have worn mine around the waist. Which obviously draws some really bizarre looks, especially living in Northern Ireland. You know, it is like an ammunition belt, you know. But no, I never used the in-car charger. It was returned quite thankfully.
I'm relieved to hear that, because I wouldn't want to. I've got a new electric car, and I get sort of, if I go on the M4, I'm like panicking.
Well, I
So
do.
over to you. Karen, did you want to say a few closing remarks, or Debbie or Betsy?
I think Debbie's going to, but Michelle, honestly, from the bottom of my heart, thank you so much. That's the second time I feel like I've put you through that torment, but you're so good at it, and you give such a proper perspective on what it's actually like to go through it. So thank you so much.
Thank you. My pleasure.
Great, by the way.
And you too. Take care. Bye.
Thank you. Bye. Thank you, Michelle. I would just like to thank everyone for attending this session. Big thank you to all the speakers and my co-chairs, and thank you to all the attendees as well. Thank you to all the people who've put questions in. I know we haven't had a chance to answer all the questions. I think it's fair to say that we're all happy to be contacted though. Via the Society. So if anybody does have questions for any of us, you can contact us via the Society. And I've also been asked to say, just a reminder to everybody to please take part in the big quiz at 6 o'clock if you can. And I think you can do that via the lobby. So thank you to everybody. I think that concludes this session.
Thank you.
Thank you very much.